Hello, welcome to the Auditory Learner, where I brainwash myself to remember content and subject matter of certain educational topics. Okay, so this is going to be the video where we're going to be talking about Chapter 8, and it will only be Chapter 8, which covers what a protist, what fungal structures are, antifungal drugs. We review a little bit of viral structure, talk about antiviral drugs, and what is PrEP and PEP, which is crazy. Anyways, okay, so let's begin really easily. First of what a protist and what a fungal structure is. This wasn't on um, the final questions of what professor wants us to review, but I think it'll be valuable for me to understand further why things are. Okay, so protists and fungi are similar in that they are eukaryotes. However, protists, they have a nucleus and a membrane-bound organelles. They can be multicellular, unicellular. They can have flagella, cilia, or extender cells for movement, such as amoebas or slime molds. They can be in water, soil, or other animals. And malaria is actually caused by a parasitic protist that lives in a mosquito. And also something that's interesting is the Irish potato famine was caused by a protist and not fungus. Now, fungi, as we said, they're also eukaryotes as well, but they have cell walls made of chitin. Most are multicellular. They don't require light, so they don't photosynthesize. And the reproduction is done by spores. So some examples of fungal conditions are yeast infections, ringworm, which sounds like a parasite, but it's not. Ringworm is a fungus. Athlete's foot and thrush. They are excellent decomposers, are important for some foods that we eat, such like, I believe one example was cheese and other things. And we also have to give props to fungi because that's how penicillin was discovered. It's a type of fungus. Some oral funguses in dentistry are Candida albicans, which is the species that causes candidiasis, or the other more common name is thrush. Usually happens in patients who are immunocompromised, they're diabetics, they might be taking prednisone, or they use inhaled corticosteroids, such as albuterol for asthma. Okay, let's before we talk about antifungal drugs, let's review just a little bit what a viral structure is. What is a virus? So now we talked about what a protist and what a fungus is, but let's just review really quick the basics of what a virus and the virus structure is. So there's like four main things about viruses. The first one is that they're technically called the robot hackers of microbiology. They're 100 times smaller than bacteria, and our human cells are 1,000 times bigger than viruses. Viruses have no organelles and they do not produce ATP. Viruses is the second thing. Viruses have a capsid, which is a protein coat. They have capsomers, which are like building blocks, and they form an icosahedral configuration, which can be helical or spherical. The third thing is that they contain genetic nucleic acids, and they are a single or double-stranded RNA or DNA, respectively. The fourth thing is that the reason why they are called robot hackers is because it comes from its capability of being an obligate intracellular parasite, which is interesting because they're not parasites, but they kind of act like one. Because when they infect bacteria, they are called bacteriophages. And in humans, they are called viruses, but they can be like pox virus or herpes virus, things like that. So they literally inject themselves into the cells by attaching to receptors on cell membranes, and they go in by endocytosis or the process of receptor-mediated endocytosis. Okay, cool. So that was viruses. Let's get back to funguses. Okay. Actually, let's get to what are the major antifungal drugs and their pharmacokinetics, their adverse reactions, and their mechanism of action, interactions and contraindications, etc. So the first couple of drugs. So we're going to be talking about one, two, three. Okay, we're going to be talking about two classes of drugs. The second class has one, two, three, four types of drugs in there. So the first class of drug is called nystatin. So nystatin binds to sterols in the fungal membrane, which increase its permeability, which also allows for the escape of critical molecules. The pharmacokinetics of nystatin is that it's not absorbed by mouth, poor absorption in the small intestine, minimal distribution throughout the body, metabolism, and elimination. So basically means it's found in your shit. Okay, the route of administration when taking nystatin is usually an oral lozenge, which is the most effective, or an oral suspension, like a mouth rinse, to be absorbed in the mouth, but it can also be swallowed, which I'm assuming if you have something in your mouth for that long, you're going to swallow some of it. So that's nystatin, okay? Well, now we're going to talk about imidazoles. These are the three different types of drugs that are very similar to metronidazole because they have a five-part ring in their structure, okay? Now, the first imidazole we're going to talk about is called clotrimazole or Lotrimin, which is the brand name. So clotrimazole is usually a topical that binds to phospholipids. You can get a prescription as an oral lozenge, but you can also find it over the counter as a topical. The pharmacokinetics of clotrimazole is pretty much the same as nystatin, except that it is better absorbed, which means that it binds to oral mucosa and intestinal mucosa more so than nystatin. Nystatin barely does at all. And this means that it can cause some gastrointestinal issues, and it's also kind of bad for the liver. It can be hepatotoxic if taken at very high dosages. The second one, we're going to talk about miconazole or Monistat. Miconazole is an over-the-counter drug antifungal, which is used for vaginal yeast infections, jock itch, or other skin infections. They can be compounded, which means they could be used with other drugs. Miconazole has poor absorption when it's topical, but that is a good thing because you don't want miconazole to be systemically distributed. You just want it placed on the site that it's needed, such as the vagina or the crotch area, since that's the way that it works best by treating it locally there. If it is absorbed, it will interfere with liver enzyme cytochrome P450, which will cause issues with benzodiazepine statins and sulfonamides. Okay, professor says sulfonamides are a class of antibiotics. Honestly, I don't remember hearing that name when we were doing the antibiotic part, but we'll keep moving. The third type of drug, so it's four, not three. Third type of drug is ketoconazole or Nizoral. This is also a topical over the counter, but it is a shampoo. This is similar with the membrane permeability, but it is more of the inhibition of purines or nucleotides, and it also inhibits enzymatic reactions. This can be absorbed by the small intestine when given orally, up to from 37 to 97%, and it goes everywhere except for hard tissues and bone. Sometimes it can go into the cerebral spinal fluid, and it does have placenta crossing capabilities. It is metabolized by the liver and eliminated through poop. Okay, for ketoconazole as well, there are adverse reactions such as GI gastrointestinal upset There is some fetal and embryonic teratogenicity. It can be liver toxic, hepatotoxic, and at high absorptions, it interferes with cytochrome P450. The last drug of the imidazoles that we're going to talk about is called fluconazole, which we've heard before. It is on the list of the cytochrome P50, P450 table that we've seen before. This one destabilizes cell membrane, and it's used for more serious blood-borne fungal infections, and it is taken orally. And the adverse reactions are the same that we just spoke about for the last drug, ketoconazole. All right. Okay, so now we're switching gears from antifungals to antivirals. All right. All right, so for antivirals, they're not really used that much in dentistry unless a doctor is going to prescribe it for a patient who has herpes warts, herpes manifestations on their cheeks, lips, or gums. So that would be probably the only time a dentist would use it, but more so, antivirals are prescribed for HIV, hepatitis, COVID-19, things like that. Also, we need to know that HIV is a retrovirus that has a mechanism of reverse transcriptase. Okay. Also, we got to know that herpes simplex virus 1 is usually sores on the lips, gums, or cheeks, and herpes simplex 2 are those found on the genitalia, and both are very contagious. There is no cure. They stay in the body forever. They just lay dormant and can be activated under certain circumstances. Okay, so we're going to talk about the next couple of things, which are the types of antiviral drugs that exist. Okay, there's 1, 2, 3, 4, 5, 6, 7, 8, 9. All right, 9. The first one is called, we're going to talk about the first one, which is called acyclovir, Zovirax. I've worked with a doctor that has prescribed this before. This treats herpes simplex 1. Herpes simplex 1, as I should have mentioned earlier, it is a double-stranded DNA virus. Acyclovir will stop the replication of the virus because it lacks the deoxyribose 3' hydroxyl and 3' hydroxyl. And so that prevents outbreaks when it is active. So it should be taken when it is active. All right, that's acyclovir. All right, stops replication of the virus because it lacks deoxyribose and 3' hydroxyl. The next drug, the second one, is called docosanol or Abreva. This one also treats herpes simplex. Similar, this one has a structure that is similar to fatty acid chain. This one prevents the virus from fusing to the host cell and is used topically, which decreases the healing time by about half a day within the first 12 hours. So it kind of tricks the virus, and it is used as a great combination when it is combined with acyclovir, since this is a topical. That's very interesting because I feel like there might be an acyclovir topical as well. Maybe we don't need to know that. Anyways, moving on to the third drug, it's called oseltamivir phosphate, which sounds familiar because that's called Tamiflu. And this treats influenza, all right, which is the flu, which is usually transferred through droplets in the air. It decreases the duration of the flu by about 3 days, but it has to be given within 48 hours of the first symptoms. And lab tests should be done to distinguish if it's COVID or influenza. But Tamiflu usually prevents the activity of neuraminidase, and it stops, which is an enzyme when influenza is infecting your cells. Um, but it stops shedding and it prevents infection, okay, when taken uh, within the first 48 hours of the first symptoms. All right. And it decreases the duration of the flu by 3 days. Okay. Some things to know is that the life cycle of the flu is very similar to COVID. This is why we need to take tests. Okay, so here's something that we need to understand very well. Okay, so we're talking about now nirmatrelvir and ritonavir, which is Paxlovid. So it seems like these two drugs are used in conjunction together when treating COVID-19. Let's talk about nirmatrelvir first, because there seems to be some differences between these two. So nirmatrelvir treats COVID-19. It is a protease inhibitor that prevents COVID maturation. And when it is exocytosed, it has no effect on the body. Okay, so that's what nirmatrelvir does. However, Paxlovid, which is ritonavir, also treats COVID-19. It was an emergency approved emergency use medication. However, it is an HIV drug, but its effects inhibit cytochrome P450, which means it increases the half-life of nirmatrelvir, which is why it is used together. 1 hour to 6 hour half-life, and causes a metallic bitter taste in saliva. So the crux of this is Paxlovid increases the half-life of nirmatrelvir. So ritonavir, which is Paxlovid, ritonavir increases the half-life of nirmatrelvir, and they're used together for COVID-19. However, ritonavir was a HIV drug, but we know that ritonavir inhibits cytochrome P450, which increases the half-life of nirmatrelvir and increases the half-life from 1 hour to 6 hours. Okay, meaning it'll stay in the system longer. Okay, so that's the good thing about it. That's the whole reason of emergency medical approval. Amazing. Okay. Imagine they told all this to the public. Anyways, let's go on to the next drug, which is zidovudine. Zidovudine. Okay, AZT, zidovudine. Okay, so here we're not talking about COVID-19 anymore. Zidovudine is the first treatment for HIV that was created and which was approved in 1987, which didn't cure it, so it only slowed it down. It is an NRTI, which is a nucleoside reverse transcriptase inhibitor. As we talked about earlier, how HIV works, it works by reverse transcriptase. This inhibits that. So this prevents the elongation of the virus and replication. However, resistance is common with zidovudine because the virus has evolved. The next drug we're going to talk about is called Caltera, also treats HIV. However, we're going to see right now that Caltera and another drug called Biktarvy are used in polytherapy. Now, let's start first with Caltera again. It does treat HIV, used for polytherapy, which is why Caltera, when you hear the word Caltera, it is a combination of two protease inhibitors, which is lopinavir and ritonavir. All right, so there we go. You see how we talked about before, how ritonavir was used to treat COVID-19 by elongating the half-life of nirmatrelvir. Here we see that Caltera, which is a combination of two protease inhibitors, is basically lopinavir and ritonavir, which prevents maturation of HIV. So Caltera is a polytherapy. of two protease inhibitors. Biktarvy is another HIV treatment, another polytherapy treatment. It is the newest type of drug, which combines bictegravir and emtricitabine and tenofovir. So that combines, like, looks like three different types of drugs. Okay, that's Biktarvy. So let's just end it off here. So, we need to understand what polytherapy is. So, resistance to antivirals is evolutionarily costly. So having resistance to antivirals is good, but highly unlikely. Polytherapy is when a virus like HIV is treated with multiple antivirals to treat several diseases. To treat severe diseases with several antivirals, to treat diseases like HIV and to prevent resistance. So when you use polytherapy for a disease like HIV, it is going to wipe out all the particles of the virus life cycle, which basically makes it more effective, because maybe the virus can have resistance to just one of those drugs, but if you treat it with multiple drugs, it's a higher chance that it's going to be more effective. Although I don't think it's going to cure you, it will slow down tremendously as far as it being a newer drug. Yeah. Rest in peace or good luck to those with HIV, or who had it and had AIDS. But anyways, so that's polytherapy. Okay. And so examples of polytherapy will be Caltera and Biktarvy, like we just spoke about. And then the last things that we're going to talk about is we need to understand what the purpose of PrEP and PEP is. And this is very interesting because I didn't know this, and it's kind of crazy. Anyways, let's talk about PrEP. PrEP stands for pre-exposure prophylaxis. This is given to very high-risk populations who are at much higher risk of developing HIV infections due to unprotected sex, drug use, or needle sharing or partner sharing. This prevents 99% of sex-related HIV and 74% of needle-related HIV. So the drugs used for PrEP are two drugs, okay? They are Truvada and Descovy, which are two NRTIs. So Truvada and Descovy are two nucleoside reverse transcriptase inhibitors. That's what NRTI stands for. So, however, these drugs, Truvada and Descovy, when used for PrEP, pre-exposure prophylaxis, it's not good if the patients or the people already have HIV, okay? So again, for PrEP is for high-risk populations. The bad thing about this is that, it can cause a severe kidney renal issues and can cause resistance, which is why these types of people need to have continuous blood tests done. That's why it's not given to everybody, right? So take care of yourself. Another thing that's kind of interesting, it's very interesting, is PEP. PEP stands for post-exposure prophylaxis. Now, this is used when you accidentally poke your fucking self with a fucking needle of an HIV-infected person, or the motherfucking patient spits blood on your fucking face or skin or whatever. And this is a fucking medical emergency. Patients are not obligated to divulge their HIV status. Man, this is insane. Maybe I'm immune. I've been poked with needles and I have not had this. Thank God. Thank you, angels. Thank you for protecting me. But anyways, that happened to me. Patient was clean as a whistle. However, if you don't know and the patient doesn't want to tell you their health status, you should assume they have it, especially if they tell you they're not obligated to tell you their HIV status. Oh man. So anyways, so post-exposure prophylaxis must be taken within 72 hours and it must be taken for 28 days. All right. So the drugs that are taken for PEP are Truvada, raltegravir, and dolutegravir. Truvada is taken BID twice a day. Raltegravir is taken BID as well, twice a day. Or you would take dolutegravir QD, which is once a day. All right, so that's going to wrap up the protist, fungal, and viral portion of the study guide for Chapter 8, Pharmacology, Summer 2022. 3. Fucking, I don't even know what year it is. All right, Dunzo.